All right, guys, so this is the first video in behavioral sciences. It covers the psychotic disorders and the mood disorders. And how I want you to learn this is think of it as a continuum, meaning you have a diagnosis that leads to a treatment and medications. And so you should be able to kind of go back and forth between these, meaning I could give you a medication and you'd say, okay, I know the side effects, how this medication interacts with others, and this is a treatment for this condition, which is based on these type of symptoms. So you should be able to kind of go back and forth on this in either direction. So I hope you find the video helpful. All right, guys, so let's get started here. It says, go straight to the last line, which of the following is the most likely diagnoses? Okay, so we look at those. Now we read it. A 21-year-old woman is brought to the emergency department by EMS after she was found walking naked in the middle of the street. She is belligerent in the emergency room and states that people are out to hurt her and that they are part of a secret governmental society that has been following her for months. She is uncooperative with history. She reports that she worked for the FBI and that she needs to speak to the hospital director so that she can apply for a job here. Urine toxicology screening is unremarkable. Blood alcohol levels are also unremarkable. Which of the following is most likely diagnosis? So when you see these, you got to ask yourself, is this relatively normal behavior, or is she out there kind of like in left field somewhere? And this is basically, psychotic behavior, okay? So when you think psychotic behavior, you got to be thinking, okay, so obviously psychosis, and then we got to basically say it's delusions, hallucinations, right? Or disorganized thinking, right? And there's got to be some combination of this. And that's what she has. So then you have to go your differential with that basically is it a brief psychotic? Is it a schizophreniform? Is it or does it go into a schizophrenia? And these are kind of our main players. And then kind of out there a little bit is going to be a schizoaffective, okay? And that just has more of a little bit of a mood component. So with this being said, everything is based on, and hear me out here, everything here is based on time, okay? And a lot that you do with the mental health and stuff is going to be based on time. Now, a brief psychotic is 1 day to less than a month, so 1 day to 30 days, right? And then, or to say less than 1 month. Schizophreniform is 1 month through 6 months, okay? It's all based on time. They all have the same symptoms, but everything's based on time. You can be delusional, hallucinating, and disorganized, but if it happens for 1 month or less, it's brief psychotic. If it happens between 1 and 6 months, schizophreniform. If it happens for 6+ months, then you're called schizophrenia, okay? So in this situation, the only thing that they give us about time is going to be, they say, for months, okay? But the good part about this question is when you look at our answer choices, the only one in here that's a psychotic disorder is going to be the schizophreniform. Now, an adjustment disorder is just basically, it's an exaggeration of your reaction to a stressor. And that stressor has to be within 3 months, okay? That's usually what kind of makes an adjustment disorder is, it's kind of like going through a divorce or something, maybe you something happened at work and you're stressed out about it a little bit above and beyond, but the stressor is within 3 months. We call that an adjustment disorder. A lot of people that we see in the inpatient unit, fall into this category. Now, on the steps, you're always going to see this substance-induced mood disorder. That is a rule out. I can't have any of this. If this urine toxicology screening was positive for cocaine, positive for meth, positive for amphetamines, I would have to choose mood disorder, substance induced. But since they said it was unremarkable, I can automatically get rid of that one. Dissociative identity is basically the new term for multiple personality disorder. Very rare. This person's not talking about having multiple personalities, so we can get that one off. And then general anxiety, that's just, it's got to be 6 months or more, and that's just kind of an exaggerated feeling of obviously anxiousness for no particular reason. So in this situation, the best answer, the only answer is going to be schizophreniform with that time frame. Now, this one says a 32-year-old man is hospitalized after neighbors called police. Now, don't worry that this is such a long problem. This is one of those problems that I want to emphasize. Okay, we gotta have this one. This is very, very, very important. If we went, which of the following is most likely diagnosis? We look at these. They're all kind of relatively close. So we go back to reading it. 32-year-old man hospitalized after neighbors called police to report that he had been singing loudly and playing drums all night, every night for the past 3 weeks. He claims that he is related to the president and tells everyone he's going to be famous singer someday. He reports his mood is the greatest it has ever been, and he has put all his time and energy into working on the best album of the century, right? This guy's got this, he's got this elevated mood, almost kind of a manic presentation. While in the hospital, he makes inappropriate sexual advances towards some of the female nurses. The patient has a history of multiple psychiatric admissions starting at age 21, okay, long history there, presenting with similar symptoms. During his last admission, the patient was hospitalized for 2 weeks for hearing voices and believing that he was being followed by the FBI. So he's got that paranoia, kind of delusional, okay? At that time, he was fearful but displayed no mood symptoms. That's important. Which of the following is most likely diagnosis? Okay. When you look at these answer choices, bipolar with psychotic features, okay? That means, you're here, you live kind of in Depressionville because you're bipolar, and then you go up to have this manic episode, and then when you have this manic episode, that's when you have your mania, your psychotic features, okay? And then you come back down to your basic depression. Delusional disorder, now that's just one where it's like, look, I can walk around saying, you know what, guys, I'm married to the, some famous actress or something like that. Well, it could be true, but most likely it's not. But I still function. If you can still function in society, that's more of a delusional disorder. But this person's obviously not functioning very well. They've been in the hospital multiple times, so I can cross that guy out. But the key is, for delusional disorder, you got to be still functional, okay? Major depressive disorder with psychotic features. Well, I agree that it's psychotic features, perhaps, but this guy doesn't seem like he has these psychotic features because he's depressed. This guy is elevated, so I'm going to get rid of that guy for now. And then I'm left with schizoaffective disorder. Now, we talked about that. Schizoaffective is like, well, I could have, I'm down here in Depressionville, and then I have these elevated moods, and then I come back down, okay? And it looks just like bipolar, right? These two look just the same. Now, here is the key thing, guys, and I can't stress this enough because this is the level where step 1 and so on are going to test you. What is the difference between bipolar with psychotic features and schizoaffective with disorder? With bipolar, you only have the delusions, the hallucinations when you're in the manic episode, okay? In schizoaffective, you would have those behaviors, the delusions, hallucinations, all along, whether you're back in your normal state, which is here, or if you're in this kind of elevated mood per se. You see the difference? In bipolar, the only time you have those symptoms is when you're in the elevated mood. The only time, and when you're in schizoaffective, you have the symptoms all the time. He'll be hearing the voices, being paranoid all the time, but then you still roll in a little bit of an elevated mood on top of that. So in this situation, in this guy, this last little piece right here is the key. During his last admission, the patient was hospitalized for 2 weeks for hearing voices and believing that he was being followed by the FBI. At that time, he was fearful but displayed no mood symptoms, okay? So he was having these delusions, this paranoia, without the mood symptom. So which of these is that? It's the schizoaffective, right? He had these symptoms without the mood component. That's how you differentiate between these two. And you better believe with certainty that on step 1 that they'll throw this bipolar one at you as choice A, okay? But you're not going to fall for it. You got to know the difference between these two, okay? And this one says, a 27-year-old man who is an executive has a 2-month history of episodes of tachypnea, dyspnea, feeling of choking, and sensation of not being able to take in enough air while at work. Findings on physical examination after the first episode showed no abnormalities. Chemistry profile, arterial blood gas analysis, EKG, spirometry, and X-ray films of the chest showed no abnormalities. Which of the following is the most likely diagnosis? Okay, it's just a diagnosis thing. So it's 2 months duration. Okay, fine. And this guy's having this elevated, kind of like worrisome, over-the-top kind of stuff. Now, when you look at the answer choices, conversion disorder. Conversion, you got to be thinking it's more of a neurological kind of symptoms, okay? And it's usually, as we say, CNS, and it's where voluntary control can occur. Okay, or I'll just put a can occur. Yeah, just one R. All right. So, but they're kind of like, I don't want to say feigning it, but it's not like it's, per se real. There's no proof that it actually exists, but it's usually a neurological symptoms. Is this a neurological symptom? No, it doesn't look like it, right? This guy's just not being able to take enough air, so I get rid of this one. Generalized anxiety is just worry for some reason that we can't explain. But remember, what's our disclaimer on that? It's got to be at least 6 months. This one's only 2 months, so that one's gone. Hypochondriasis, well, this guy is the one where, it's like having this, as they say, a preoccupation with having a disease and not so much, rather than focused on the symptoms. But this guy doesn't seem like he's focused on the disease or anything like that. He just can't get enough air. He's worried. He's an executive. So it's not necessarily that one. And of course, the answer choice is going to be this guy's having a panic disorder. But now to clarify this, we got to know, we gotta really break these down. And so there's a way of doing it. You can say if things are conscious versus more unconscious, per se, in terms of how the patient is feeling. So if it's unconscious, meaning they believe it subconsciously, you're thinking somatic symptom. And that's where this conversion jumps in. If it's a conscious choice, okay, then we're going to ask ourselves, is it primary gain or secondary gain? Okay. Now, primary gain, they know what's going on. This is going to be our factitious disorders, and this is going to be like our Munchausen. Okay. I don't know how to spell that one, but I'm going to say Munchausen, right? They make themselves sick, or they kind of feign the disease. For secondary gain, this is just going to be our malingering, right? Maybe they need housing. Maybe they need, there's something in it for them per se. Now, the unconscious one, this somatic symptom, this is the one where we're going to have our conversion, and you just got to memorize some key words in here, right? They can't explain the symptoms, science or medicine can't, but the patient swears by it. But these are going to be a neurologic symptom. Another one we're going to talk about is going to be the somatic or somatization disorder. But the key with that one, it's multiple systems, okay? Multiple systems. You're talking like GI, like sexual dysfunction, things like that. And you can even have neurological in there, but the difference is conversion is just neurologic. The somatization disorder is going to be multiple systems, okay? And you can have the hypochondriasis in this, like we said, it's more of a preoccupation with the disease rather than the symptoms. The couple ones that I also want you to know is going to be this, and this is going to be important. I can see this one kind of coming up. It's going to be called illness, anxiety disorder, and I want you to differentiate that one between and this one, psychological factors affecting medical condition, okay? Because this one I can see happening in today's society, right? Illness, anxiety says, oh my God, I'm worried about catching something. Ma'am, do you have any of the symptoms? No. Do you have the disease? No. But I'm worried about catching something. That's an illness, anxiety. They don't have the disease. Now, psychological factors affecting a medical condition is they have the condition. They have something, and then it just overtakes them. It overwhelms them. It's almost like saying they have, say, like asthma, and then they're like, whether they're like, I say like abusing an inhaler, but they're thinking, oh my God, this is going to happen to me. I can't do this because I have the condition, and the condition is confirmed. So that's the difference between these two. They don't have the disease in this one, but they're worried about it. In this one, they actually have a disease, and they're worried about how it's going to affect them. Okay? Conversion, think neurologic. Somatization, think multiple systems, and go from there. All right? So the correct answer in this one's going to be, obviously, panic disorder. And this one says, which of the following is the most likely cause of the patient's condition? Now, we look at these, and obviously this looks like an old person kind of thing. A 65-year-old is brought to the physician for assessment of a 7-month history of progressively strange and erratic behavior. He has been very distractible and impulsive in his behaviors. He has stopped bathing and taking care of himself. He has been rude and unkempt. When eating, he is known to stuff his hand in his mouth. He's been having some difficulty with memory during this time. Medical history is significant for hypertension and control with the beta blocker. Neurological exam shows no focal signs, but the grasp and the snout reflexes are prominent. Which of the following is the most likely cause of the patient's condition? All right, so he's 65. Looks like there's behaviors that are really a prime issue. But when we look at our answer choices, they're kind of digging down the whole kind of the old person differential here. And here's how I want you to attack these, okay, in a 7-month history. You need to know whether it's dementia versus delirium. Now, how do you tell the difference? This is going to be gradual. This is going to be sudden, right? And a lot of times you get that in real life just by calling the family saying, hey, look, well, how was he like last week? And if it's all of a sudden change, you better be jumping on delirium, and you better do a medical workup and making sure that there's not something underlying all this. In dementia, it's gradual, right? Now, this has been a 7-month, so that's reasonably gradual for our purposes, right? When I say delirium, it's going to be like days, okay? That's the change. So when it comes to dementia, here's how I want you to do it, especially if they're in this age range. You have Alzheimer's, you have PICS, you have Lewy body, you have vascular dementia, you have like HIV, and you can go on and on with all the small causes. But these are the majority. Okay, these are the majority, probably even right through there. All right. So with this one, he's having erratic behavior. So we know that Alzheimer's is more just gradual. Now this is going to be your one that's more of just the default. So you got to go through the other ones, and then if you still don't know what it is, then you choose Alzheimer's. PICS, okay? PICS is also known as frontotemporal, okay? That's the one to where you're going to have the personality changes, okay? Personality changes. Lewy body, you're going to associate that one with visual hallucinations, right? There's going to be something that's a visual hallucination going on. Vascular, they're going to have to give you a lipid profile or something to say they got some vascular issues, like they have a lot of strokes, okay? They have a history of strokes. That's going to support that. And of course, HIV, they got to give you something that's going to support that. High risk sexual behavior. Maybe they're on some type of antiretrovirals. That would support that. But in this situation, it's 7 months, so it's gradual. It's erratic behavior, and based on that age, the best answer would be PICS. So when I look at these, vascular dementia, probably not. There's nothing that supports that. Not saying it's not totally in real life, but we don't have enough data in this question in STEM to support that. Is it major neurocognitive disorder, dementia, Alzheimer's like? Well, possibly. And of course, they want you to jump on that, but don't do that because this is going to be more of a diagnosis of exclusion, okay? Normal aging. On step 1, they're going to give you a ton of answer choices that'll always say normal aging. So you either better be used to seeing that, and you better get used to either using it or not using it, okay? So that's always going to be on your answer choices. But you can tell when he's 65, a 65-year-old should not be going through this. This is not normal aging. Huntington's, as you know, that's, CAG, kind of a repeat, the whole classic failing arms, is it caudate nucleus, autosomal dominant, all that stuff, kind of a totally different topic. So this guy's not doing any of that, and there's no family history that we can see. So that one's off the board. And of course, we're left with PICS, which is frontotemporal and personality change. The other thing that I want to stress, and I want you to know this, is Alzheimer's, right? They're going to default to Alzheimer's, but as you know, on step 1, nothing is ever that easy as far as the answer choices. We hope we get something as simple as this. But with Alzheimer's, you'll know it's the diagnosis, but they're going to say which of the following is associated with late onset, early onset of Alzheimer's. And I want you to know this, early onset, which is, 65 is when we start getting like 1%, 2%, 3%, of the population. So anything less than 65 would be an early onset. But when you say early onset, I want you to think amyloid precursor protein, which is located on chromosome 21. And I want you to think pre-senilin 1 and pre-senilin 2, okay? Early onset, amyloid precursor protein 21, and then pre-senilin 1, pre-senilin 2. Know that, okay? If it's late onset, how many letters are in the word late? 4, right? I want you to think ApoE4. So late onset, ApoE4, and then the protective is going to be ApoE5. If you have that gene or whatever, ApoE2 is protective, ApoE4 is indicative of late, right? 4 letters in the word late, ApoE4. And then early onset, amyloid precursor protein 21, which is on chromosome 21, presenilin 1, presenilin 2. Know those, okay? Just know them. Good. This one says, which of the following is the most likely diagnosis? We look at these, looks like they're digging down the eating disorder, perhaps. I don't know. It says, 18-year-old college freshman comes to the clinic with her parents, urging for evaluation of a 6.5 kilogram, 50-pound weight loss over the past 4 months. She has had increasing difficulty concentrating on her schoolwork and has begun to miss class. She avoids friends and often skips meals while watching television alone in her room. She sleeps fitfully and often awakes at 4:30 a.m. and is unable to go back to sleep. Her weight is currently in the low normal range. She agrees that something is wrong and feels guilty about her academic performance, which is the most likely diagnosis. Well, you can tell they're trying to have you jump on this whole eating disorder thing. But, you know, if you notice, the one thing they didn't give us on this is going to be BMI. Now, when I took the STEP exam, there was at least one question that I remember vividly, that if you don't know what a good BMI is, or a low or a high, you could not answer that question. So between 18 and 25 is normal, okay? So if you are less than 18 BMI, that is abnormal, and that's when you'd start jumping on anorexia nervosa. But in this, did they give us BMI in this thing at all? No, so we can't really, you know, I really can't say that right now, because they didn't give us that. And they talk about weight loss, but, you know, I don't know where she started. So we look at our other choices: conversion, major depression, possibly obsessive compulsive. I don't really see the obsessions or the compulsive behaviors. Schizophrenia, it's not like she's, again, is she delusional? Is she paranoid? Is she disorganized thinking? I don't really see that one. And are there any neurological issues that we talked about for conversion? No. So now we're down to anorexia, bulimia, and major depression. Now again, BMI of less than 18, I got to go with anorexia. If it was bulimia, it's usually a BMI of 18 plus, right? It's usually a normal weight per se. But again, we don't know what that is. Now, major depression. What's that acronym that we always do for major depression, right? SIGI caps. And it's, you know, S is sleep, right? Interest level, you know, guilt feelings, energy, concentration, appetite. They call it psychomotor agitation. Oops. And then, you know, suicide. So we got to have at least 5, right? So in this one, college freshman comes urging evaluation, so she's got weight loss, right? So perhaps there's the appetite one. Over the past 4 months, she has increased difficulty concentrating. Okay, so maybe I can see what they're doing here on schoolwork. She's begun to miss class, avoids friends, skips meals, back to appetite, alone in her room. She often awakes at 4:30, you know, poor sleep habits, whether it's too much or too little. And then she feels guilty. I mean, you can just see and there's probably low energy buried in there somewhere, right? So she didn't say she's suicidal, but look, she's got 1, 2, 3, 4, 5, 6 of these guys. You only had to have 5. It looks like she's headed toward major depression. Now, there's got to be a time frame of this, right? It's got to be greater than, greater than 2 weeks. And this has been going on for 4 months. The best answer, the only answer, is going to be major depression on this. Now, you can see what they wanted to do. They wanted to hook you into these guys. And those aren't bad choices, but we don't have the data to support them. You better know these for step 1. Now, again, the ones in that category that you got to differentiate, and that's all you got to do, is just make sure you know the list, know how to break them apart. Anorexia, bulimia, you got the binge eating, okay? And then you got it's called the avoidant, restrictive food intake disorder, okay? And I guess they put like ARF, I'm going to say it's ARF, okay, I could be wrong on that, but I think it's pretty much this. So you have these 4, okay? Now, with these 4, how do you differentiate them? Well, anorexia, again, you could have restriction, But look at this. You can have restriction, binge, or purge. Believe it or not, in anorexia, you can have restriction of food, binging, or purging. Well, guess what? So can bulimia. So you can still have these things. I'm sorry, with the bulimia, you got to have the binge eating with the compensatory. So fine. So it's all basically it's all the same. Okay, that's essentially how I learned it. Because the one differentiator between those is going to be the BMI, and they have to give you that. Okay, so if it's less than 18, you're jumping all over anorexia. If it's the BMI is greater than 18, you're jumping all over bulimia. Now, if it's binge eating, there's no purge, right? It all looks like that, but there's no purging. There's no compensatory behaviors after you binge eat. And then the avoidant restrictive food intake disorder is just basically someone not meeting their nutritional needs. Okay, but you got to be familiar with these terms. They're going to hit you on these, but you never know. These will be distractors, but they might, you just got to know them. No purging here. You can have purging in both of these. It's the BMI that's going to save you on this. You better know what normal is. Okay? All right. Which of the following psychiatric disorders is most likely to be present in this man? All right, so we look at the answer choices: major depression, antisocial, OCD, PTSD, and schizophrenia form. All right, so we got a psychotic disorder, we got a personality disorder, we got like more of an anxiety disorder, and a mood disorder. 33-year-old man comes to physician for a routine exam. He tells the physician that he gained weight, but that he does not enjoy eating or many other activities. Now, what's that called? What's the fancy term for when you just have lack of interest in life, right? Anhedonia, okay? He says that he needs at least 11 hours sleep, but still feels fatigued most day and has difficulty concentrating. All right, so sleep, concentrating, where are we headed, right? It sounds like we're doing the Siggy Caps thing again, okay? He's 5'10" and weighs 198, okay? Which of the following psychiatric disorders is most likely present? Well, antisocial personality, if we were to really dig on that one, where's that going? That's the guy that's the troublemaker, right? That's the guy that's breaking the law. We have an oppositional, defiant. This is where we start, right? And then we have a conduct disorder, right? Now the thing is, these guys are kids, right? This is for children. The kid in the classroom is just a little bit rambunctious. We're going to call him oppositional defiant, right? The kid less than 18, right? Less than 18 years of age, the kid who breaks the law is going to be conduct, okay? Now, once that kid hits 18, it's like, congratulations, son, you just hit antisocial personality if you're one of those people who chronically breaks the law, or they hurt animals, something like that. But anyways, this is your differential. Oppositional defiant is just a kid that's a little bit, he's a little bit bad in class. Maybe he talks out, always, disrespects the teacher per se, but he's not breaking the law. This guy breaking the law, he's a truant. He's the one that's going around, breaking into people's homes right after school or something like that. And then once he turns 18, it becomes antisocial. This thing has nothing to do with that. This guy never broke the law. This guy doesn't have some type of obsession or repetition with some type of compensatory behavior, so it's not OCD. I don't see anything that talks about a traumatic incident or avoidance of a situation. I don't see and then remember, schizophreniform, this was our psychotic disorders. Is this guy delusional, hallucinations, or disorganized thinking? No. And remember how we would do that? Less than a month, between 1 day and 1 month, it's brief psychotic. Between 1 month and 6 months, it's schizophreniform. And 6 months plus, it's going to be schizophrenia. But in this case, this guy looks like he has the Siggy Caps because he's got the anhedonia as well. It's going to be major depression. Yeah. One thing just crossed my mind, since we were talking like you got to know certain things for the exam. IQ, total side note. What's normal IQ? You're going to be thinking 100, okay? And then plus minus 20. So if you go this way 20, if it's 80 or less, things aren't looking too good for you. If you're 20 this way, you're exceptionally smart. So just remember, average IQ, you're going to say 100, because there was a question on my exam where they had the IQ down less than 80, so you had to know there was some type of intellectual disability going on there too. All right, Which of the following is the patient's strongest risk factor for suicide? So without even reading this, which of the following is the patient's strongest risk factor for suicide? Depression symptoms, family history of completed suicide, history of past suicide attempt, or lack of social support. Now, if you knew nothing else without reading this, what should your answer be? The greatest predictor of suicide is someone who's tried it in the past. Period. End of story. Know that. The greatest predictor, especially if you're interviewing somebody, ask them, have you ever attempted suicide in the past? And that is the greatest predictor of them perhaps doing it again. Okay? Not too much to kind of further elaborate on this one. Says she is most likely suffering from which of the following? Looks like there are a bunch of mood disorders on here. So let's see. It says 28-year-old woman presents to your clinic complaining of fatigue. She states that her fatigue lasts her for 4 years and that she is not happy during the same time period. She cannot think of any enjoyable activities. There's our anhedonia again, and describes herself as worthless multiple occasions. She denies suicidal ideation, loss of appetite, or changes in her sleep pattern. Okay, so it's almost like, you know, we were trying to do the Siggy caps here, but for some reason on this question, they wanted to emphasize that she denies suicidal. She denies the loss of appetite or changes in her sleep, but she has trouble enjoying activities, so that's the anhedonia. It sounds like lack of interest. She feels worthless. So it's like she's got a couple, but does she have at least 5? And she doesn't look like she has 5. So we can't really get the diagnosis of major depression on this one. Now, does she have a mood component that's an elevated? Because here's bipolar 1, bipolar 2. Both of these kind of like this. Here's bipolar. You have depression. And then you go up and have some type of elevated mood that can get you in trouble. We're talking something where it's lack of sleep. You know, you want to write the greatest American novel. You want to do something a little bit out there. It might get you into the hospital. This person doesn't have that elevated mood, right? So I don't get that one. Bipolar 2 is the same thing, except it doesn't get you in trouble. It's like I have a little bit of an elevated mood, but you know, I'm not rocking the boat anywhere. But again, I don't see anything that talks about elevated mood, because again, but bipolar, these people do live down here in depression as well, but this example doesn't give that elevation. And then dysthymic disorder is basically someone who doesn't meet criteria for major depression, and it's greater than 2 years, around 2 years or greater. You're looking at dysthymia or dysthymic disorder, which is what this one looks like. The last choice, borderline personality, that's a personality. It's the cluster B. It's associated with splitting, right? People are either all good or all bad. Very popular answer choice on all your STEP exams, okay? Very, very popular, because it's, gosh, you see it all the time. If you work in psych, I can tell you that that's just a perpetual thing. Now it says drug therapy is most likely to involve which of the following neurotransmitter? Good, because I like questions like this. It says a 35-year-old woman has a 12-year history of chronic paranoia, auditory hallucinations, and believes that people inside her television are talking directly to her. Drug therapy is most likely to directly involve which of the following neurotransmitters? All right, so she's got paranoia, auditory hallucinations. So basically she's got a psychotic disorder, right? How do we treat psychotic disorders? Now remember what we talked about briefly on this, is that when you're studying for the STEP exam, they're going to make, you're going to have to come up with a diagnosis, okay? And then you have to associate that with some type of treatment. And with that treatment, you're going to have medications, and you're going to have to know how these medications interact, going backwards, forwards, and with other meds. But the key is, they could give you medications, and then you have to know the mechanism and how they interact, and you might have to work your way backwards to a diagnosis. So be able to work on this kind of continuum back and forth. This question is pretty basic, pretty straightforward. You know it's a psychotic disorder. How do we treat psychotic disorders? Out of these, you're looking at dopamine, right? More specifically, D2. You better believe they're probably going to put D1, D3, all that stuff on your STEP exam, but you're going to know it's D2. Adenosine, that's, if you were to work on, like, say, caffeine, as you're using energy, ATP, throughout the day, you will build, as this clips off, you're left with this adenosine, and then it goes to basically a certain part of the brain where you have these adenosine receptors, and then as they fill up, you get tired. So what does caffeine do? Caffeine gets and sits on that space before adenosine can get there, and therefore you need, you stay awake. You don't get as tired, and therefore you need more and more caffeine as time goes on because the body adapts. Anyways, long story short, adenosine is going to be the caffeine. GABA is going to be your main inhibitory guy, one of your inhibitory guys in the CNS. Glutamate is going to be your excitatory. All right. Now, if I was to say, as far as, I don't know, GABA, not too many they ask questions on this. Glutamate, it's interesting about glutamate. It is excitatory, and it works on the NMDA receptor. Okay, this is just more of a side note, not so much psych, but glutamate, excitatory, NMDA receptors, and this is the one where PCP, ketamine, and dextromethorphan. Okay, those are all really common, but that's the mechanism. So if you get a question like this, you can work backwards and say, yep, that's the NMDA receptor, and that's also on glutamate. I think Namenda, Aricept, Namenda, the Alzheimer's medication also works on that. So, again, just kind of, this is how you approach step one. You look at the answer choices, and then you just kind of start working. You can work backwards, forwards and backwards. So if I was to summarize kind of this whole thing that we're doing here, I would say this. You got to know psychotic disorders. And remember, psychotic, you got delusions, hallucinations, disorganized thinking, right? And with that, it's brief, psychotic, schizophreniform, and maybe if you're just listening to this, I know don't just ignore the sloppy writing, and then schizophrenia. Everything is based on time. 1 day through 1 month, brief psychotic. If it's 1 month through 6 months, schizophreniform, okay? And then if it's 6+ months, it's going to be schizophrenia. All have the same symptoms: delusions, hallucinations, disorganized thinking. It's just a matter of how long, and they gotta give you this in the question stem. That's where the testing questions will come from. If you have mood disorders, okay, you're talking depression, you're talking bipolar, okay. These are your mood disorders: bipolar 1, bipolar 2. They have the elevation with the mania here, or it's kind of a hypomania with bipolar 2. What do we say? That if we have a person, if it's almost like this, a person in schizophrenia and a person with bipolar had a kid or whatever, if those two diagnoses had a baby, it would be called schizoaffective, because this is the person who hears voices when they're normal down here in Depressionville per se, and they hear voices when they have the elevated mood, and they hear voices down here and they have voices up here, right? They hear voices all the time, even when they're not in an elevated mood state. Whereas a person who has bipolar with psychotic features, the only time that they hear voices is when they're in that elevated mood state. Okay? Know that difference. And then we talked about the anxiety disorders, but review this, guys. This is the good. If you know this, you're going to be just fine when it comes to the mood disorders and such for your step one.